Hello, my name is Stephanie Sanchez, and my dental health initiative and promotion is to increase the proportion of low-income children and adolescents. Healthy People 2020 has identified the Oral Health Initiative to increase the proportion of low-income children and adolescents who received any preventive dental service during the past year. The target population is 33.2%. The baseline information is 30.2% of children and adolescents aged 2 to 18 years at or below 200% of the federal poverty level received a preventive dental service during the past year in 2007. The target setting method is for a 10% improvement. The data sources are Medical Expenditure Panel Survey and AHRQ. The data disparities are location, sex, disability, race, and ethnicity. Take a moment to play this video of this low-income Hispanic woman taking her daughter to the dentist to receive preventive care covered through her daughter's Medicaid. This article was published by the American Journal of Public Health, which is explaining racial ethnic disparities in children's dental health. It was a cross-sectional national survey conducted by the National Center for Health Statistics at the CDC, whose participants were U.S. children who were Black, white, and Hispanic. The results were that Hispanic children had the poorest dental health and lowest preventive dental care utilization, followed by Black and then white children. This article is called Factors Associated with Receiving Treatment for Dental Decay Among Medicaid-Enrolled Children Younger than 12 Years of Age in Iowa. The study design is a bivariate analysis to examine children's characteristics who screen positive for decay and receive treatment within 6 months of their initial screening. The purpose is to evaluate iSmile program effectiveness. The results of the data is that 11% of children were positive for decay. 24% of children with decay received treatment based on a Medicaid paid claim. The goal is to create an educational program that travels to Section 8 housing and Title I school to promote and educate parents to help increase preventive dental services in their children and adolescents. We will need to contact the homeowner association of the targeted community and school administration to get this started. Once the issue has been identified, we can implement a plan within the community to help each other out, such as carpooling or finding an interpreter. Program environment would include Title I elementary, middle, and high school, and Section 8 community clubhouse. Pros to this would be that the clubhouse will be at walking distance, and the school meeting will be held at night so parents will not have to miss work. The cons in these situations is if they need transportation to the school, if they have a language barrier, or just lack of interest. Program workforce would include school administrations, homeowner associations, interpreters if needed, and student and registered hygienists. Here is a sample flyer school officials could send out to the parents to attend this educational meeting. Possible sources of funding could be requested from the federal block grants, the maternal and children's health services, insurance plans such as Medicaid and Children's Health Insurance Program. We can also request fundings from local health department and have fundraising from dental hygiene students. The objective is to increase the proportion of low-income children and adolescents who received any preventive dental service during the past year. Our goal is to have an efficient group to travel to low-income areas to educate the parents the importance of preventive care and receiving any restorative work needed. It is also to increase children and adolescents to continue receiving their dental services and to increase dental services of children and adolescents who have insurance but do not utilize the benefits. The program measures and assessment that will be used will be the DMFT/S, which determines status of dental caries, activity of decayed, missing, or filled teeth or surfaces of permanent dentition and primary dentition. We will also be using the plaque index, which assesses thickness of plaque in gingival area in evaluating each of the 4 tooth surfaces, which are the distal, facial, lingual, and mesial, for plaque retention. My time frame for this program implementation for successful assessment of change will be 3 years. It will begin with the initial assessment, and then a reassessment at 6 months, and yearly after that to see if the patient is utilizing their benefits of their insurance and getting the preventive care needed. The research method for evaluation of this data will be a quantitative study in order to collect data to evaluate the number of increased low-income children and adolescents receiving preventive care and the continuance of patients already receiving their preventive care. It would also determine the amount of patients who have received care in the past but discontinue to carry on with their services. The data analysis will include descriptive statistics, which conducted a cross-sectional national survey, which characteristics involve demographic, socioeconomic, maternal health, and also a bivariate analysis, which the characteristics are age, race, ethnicity, dental home, and rurality of residence. This table shows characteristics of Medicaid enrolled children who screen positive for decay at their initial screening in Iowa. 1,816 of the children screened positive for decay. In this descriptive analysis, nearly 67% of the children were white non-Hispanic, 92% had a medical home, and nearly 70% had a dental home. Slightly more children screened positive for decay were younger than the age 5 years compared with children 5 years and older. This table shows the bivariate associations between Medicaid qualified children characteristics who screened positive for decay and received treatment within 6 months. Of the 1,816 of the children who screened positive for decay, only 24% of those children received treatment. Dental home was significantly associated with receiving treatment. Lack of a medical home was also shown associated with lack of dental treatment. This figure explains proportions of dental health gaps among white and African American children by study variable categories of the National Survey of Children's Health. The lower socioeconomic status was the most relevant for explaining the lower use of preventive dental care among Black children. Here you can see that lower socioeconomic status was most relevant for explaining the higher rates of fair or poor dental health rating. The lower socioeconomic status also explains 54.6% of the lower use of preventive dental care among Hispanic children. The null hypothesis is that there is no change in low-income children and adolescents who received any preventive dental service during the past year. The alternative hypothesis is that there is an increase of preventive dental services in low-income children and adolescents. The alpha level is set at 0.05 p-value or power. If we reject the null and change does occur, then there is a type 1 error with 5% error value, and the alternate was correct. If we fail to reject the null and no changes occurs, then the null is correct and the alternate is wrong.